Hello and welcome everyone. Today we will do the literature review of recombinant ADAMTS13 in congenital thrombotic thrombocytopenic purpura. This paper was published on 2nd May in NEJM. So coming first to the pathophysiology of TTP. In this, there are multimers of von Willebrand factor on the endothelial cell. So there are two types of scenario. A normal case where you have this ADAMTS13 molecule which breaks down the multimers into smaller portions. While there are some patients who are deficient in ADAMTS13, which is activity of ADAMTS13 less than 10%. In that, you find very ultra large multimers of von Willebrand factor. This ultra large multimers of von Willebrand factor activate the platelet, resulting in intravascular thrombosis with tissue ischemia and hemolysis. Now, congenital TTP is an extremely rare thrombotic microangiopathy with a prevalence of approximately 0.5 cases per million. The triggers for acute TTP include infections, trauma, and pregnancy. Standard treatment options primarily involve replacing this ADAMTS13 through prophylactic or on-demand infusion of fresh frozen plasma or FFP, which is treated with solvent detergent processes, or plasma-derived factor VIII von Willebrand factor concentrates. These treatments are dependent on donor plasma and also provide a limited amount of ADAMTS13. Prophylactic treatment typically requires lengthy and burdensome infusions in hospital setting with the risk of severe allergic reactions that can limit the treatment. This particular study describes a phase 3 randomized controlled crossover trial evaluating the efficacy of recombinant ADAMTS13, that is TAK-755, versus standard therapy for both prophylactic as well as for on-demand treatment in adults and children with congenital TTP. The study is a phase 3 multinational prospective open-label randomized controlled 2-period crossover trial assessing the efficacy and safety of recombinant ADAMTS13 versus standard therapy in congenital TTP. Participants include patients of all ages enrolled between October 13, 2017 to August 12, 2022 at 34 sites across the European Union, United States, United Kingdom, and Japan. The trial design involved collaboration between the sponsors and 8 academic authors. The sponsors collected and analyzed the data. Data integrity and adherence to the protocol was assured by the authors, who also prepared the manuscript drafts with medical writing support funded by the sponsors. Confidentiality agreements were signed by all authors with the sponsor, restricting data disclosure without prior written consent. The trial includes 2 cohorts of congenital TTP patients, one who required prophylactic treatment to prevent an episode of TTP. Another was on-demand treatment for patients who already had a TTP event. Eligibility criteria were patients from 0 to 70 years with congenital TTP, which is confirmed by molecular genetic testing and ADAMTS13 activity of less than 10%, who tolerated standard therapy without any severe side effects. Patients free from acute TTP events at screening joined the prophylactic cohort, and those experiencing an acute event at screening entered the on-demand cohort. The prophylactic cohort uses a crossover design for a within-patient controlled comparison, aiming to reduce imbalances between randomized group due to the rarity of the disease. Patients in this cohort are randomly assigned 1:1 ratio to start with either recombinant ADAMTS13 given at 40 international units per kg body weight or standard therapy during the initial crossover pharmacokinetic period, followed by a 2-month period where they alternate treatments and a final 6-month period where all receive recombinant ADAMTS13. Now, standard therapy options include FFP, solvent detergent treated plasma, or plasma-derived factor VIII von Willebrand factor concentrates, administered weekly or bi-weekly based on prior treatment and investigator judgment. In the on-demand cohort, patients were also assigned 1:1 ratio to receive either recombinant ADAMTS13 with a dosing of 40 international units on day 1, 20 on day 2 and 15 on day 3 until 2 days post-resolution of the TTP event. From resolving an acute TTP event, patient in the on-demand cohort may transition into a prophylactic cohort. Primary outcome. The primary outcome was the occurrence of acute TTP events among patients who were receiving prophylaxis with either ADAMTS13 or standard therapy for over 3 periods. An acute TTP event was defined as a significant decrease in the platelet count or an increase in lactic dehydrogenase levels. The definition of an acute TTP. An acute TTP event involved a reduction in the platelet count by at least 50% from the baseline or below 1 lakh per microliter, combined with an elevation of LDH to more than twice the baseline of the upper limit of the normal. The secondary efficacy included various TTP manifestations such as thrombocytopenia, elevated LDH, increased creatinine, neurological symptoms, and abdominal pain. Safety was also addressed in this, where the immunogenicity to the recombinant ADAMTS13 was also checked. Pharmacokinetic and pharmacodynamic. Analyzed using the assay with key variables like maximum ADAMTS13 activity post-infusion, average activity over 168 hours period, and overall activity curve. Antibody presence was assessed using ELISA and a modified Bachelor assay. Exploratory efficacy outcomes included composite TTP manifestation and subacute TTP events defined as series of clinical and lab changes indicating less severe but significant progression of the TTP. Due to the rarity of the congenital TTP, the trial focused on benefit-risk profile of recombinant ADAMTS13 without sufficient power for definitive statistical hypothesis testing. Results are presented as point estimates with 95% confidence interval without adjustment for the multiplicity. An interim analysis was planned after 30 adults or adolescents in the prophylactic cohort who had completed at least 3 periods to assess early indications of efficacy, safety, and pharmacokinetic response. So coming to the results, recombinant 13 followed by standard and standard followed by recombinant 13. You have 21 patients here, 27 patients over here. Total 48 patients were included. So the median age was 42 in the ADAMTS13 first and 27 in the standard therapy first and 33 for the overall. If you look at the distribution, most of the patients were adult. In the younger age group, you have very limited number of patients. Majority were female, nearly 60%. Median BMI was 24. Most of the race is white. Median age at diagnosis was quite different in the two groups. Blood grouping were more or less similar. Acute TTP event in 12 months before the enrollment was roughly similar. Subacute was also similar. Pre-trial treatment for congenital TTP was mostly done with FFP. So if you look at the outcomes in terms of the TTP, most of this is favoring the ADAMTS13, except the increased creatinine, which is, though not significant, slightly tilted towards the standard therapy. Apart from that, almost everything is significantly better in the ADAMTS13, especially the composite manifestations. So if you look at the adverse events, then they were less, especially in the recombinant 13 group. There was no major adverse events or antibody reactions seen with the recombinant ADAMTS13. So this is the days and the dose mode that was given. The red is showing the ADAMTS13, the blue is the FFP, green is the plasma treated solvent detergent process, and yellow is the plasma derived factor 8 and volume concentrate. So the activity of ADAMTS13 was much better with the recombinant effect. So recombinant ADAMTS13 approval as of November 23 is approved by FDA for routine prophylaxis and on-demand treatment for congenital TTP. Interim analysis of the phase 3 revealed that patients receiving prophylaxis with recombinant ADAMTS13 experienced no acute TTP event and fewer TTP manifestations, maintaining approximately 100% normal activity for a long period of time. Thrombocytopenia is frequently observed, indicating ongoing subclinical disease. Prophylaxis with recombinant ADAMTS13 appears to prevent long-term damage. Safety profile, it is more acceptable safety profile compared to the standard therapies. And immunogenicity during the 12-month prophylactic period, no patient developed any neutralizing antibody. Pharmacokinetics shows higher and more consistent activity levels with lower variability than standard therapy, which typically shows higher variability in the ADAMTS13 activity, as we saw in the graph. It is challenging to compare the TTP events from this trial with previous studies due to the differing entry criteria and conservative definition in this trial to define a TTP event. So the limitations of the trial. It is an open label trial and the volume difference was very apparent, so no, it is not possible to mask what you are giving. Statistical power was not there, so the differences that you are seeing are not statistically powered. There is limited pediatric data, as we have seen, mostly adult patients. The natural history and lack of a control data is there because all the patients are getting some kind of a treatment. We still don't know, even from historical controls also, what happens if patients don't receive these prophylactic treatments. The next is variable definition of a TTP event, and finally the continuation and attrition. The study is still ongoing and there is a lot of attrition. And so to conclude, the effectiveness is quite significant. You see very good activity in terms of reduction of the TTP manifestation and ADAMTS13 activity. Safety profile is very good, no serious immunological effects, no antibodies observed even after 12 months. Pharmacokinetic profile is predictable, not like FFP and others. Now, clinical implication is the results imply potential long-term benefits in preventing progression of the congenital TTP, reducing the burden of the disease, and considering the chronic association of TTP with stroke and kidney disease, this can have very significant manifestations. So what are the impact? How can we use this? We can use this for prophylaxis, but then the thing is you need to have very good patient selection. It doesn't mean that you give to any person who comes with a risk of congenital TTP to start this therapy. The next is monitoring and long-term safety. The monitoring has been done for just 12 months. We still don't know what are the long-term outcomes. Is it really going to reduce the stroke or the kidney disease in the long term, or it has some long-term serious adverse effects? Those are not really assessed as of now. And cost effectiveness is also a factor. As we have already discussed, there is no control group over here, so we don't know if spending so much money on this is actually benefiting even monetarily to the patient, because the events that can occur are not yet clear what exactly it's preventing. So we need further research in terms of cost effectiveness, long-term outcomes, and patient selection. So the final recommendation is, based on the interim trials, there is a strong case to consider this as a prophylactic treatment for congenital TTP, but in selected group of patients. The decision should be individualized and made with consideration of the patient's clinical history, the risk of adverse events, potential benefit from the therapy, and the evolving nature of the clinical evidence. Thank you for your patience.